We're at the CROI in Seattle, and we're here with Richard Hayes and Sarah Fidler. And we're hoping that we can learn a little bit about testing, and that there is a study that you're doing. And they're from UK, and I'm going to give you the opportunity to tell our audience what your affiliations are.
So my name's Sarah Fidler. I'm a professor of HIV medicine at Imperial College, London, and I'm a clinician, so I've looked after people living with HIV for the last 25 years and involved in academic research.
And I'm Richard Hayes. I'm Professor of Epidemiology and International Health at the London School of Hygiene and Tropical Medicine. I'm an epidemiologist, and I've been working on HIV prevention, mainly in Africa, for the last 30 years.
And on that, before we get started, we've been acknowledging some of the researchers that have been doing this good work for so many years. And it's been 30-some years since this virus has taken off, and many people have invested their whole entire careers in it. So it's really appreciating that we appreciate the work, and as activists, and I'm sure we can speak the same for all the people who are living with AIDS today because of the work that's accumulated and the science that's happened. So the work that you're doing is in testing. And where's the trial being run? And tell us about the trial.
So the trial has recently finished. It's called HPTN 071 PopART. PopART is probably easier to remember. Mm-hmm. And it's been conducted in Zambia and the Western Cape in South Africa. And we've been working in 21 urban communities in those quite challenging environments in Southern Africa, which have very severe HIV epidemics, some of the worst in the world.
Are these urban settings? Or?
They're urban settings, yeah. So really quite difficult places to work with high levels of migration and morbidity. They're mostly quite poor communities. So yeah, many challenges really, but they're really where we need to work because that's where the epidemic is at its worst.
Okay, and you want to tell us about the...
Why don't you say a bit about the study, Sarah?
So the study is what's called a community randomized trial. So it's a sort of different idea than the sort of clinical trials we're used to seeing. So an entire community is defined around, in our study, around a healthcare setting. So a healthcare centre, and then the people who live within that catchment area. And in this trial, we had 21 communities. We worked really closely with the local communities to set this up. And it's always difficult to get consent from everybody in a community. It's not like an individual person says, yes, I'd like to be part of this. And our total population, we think, in the entire study is about 1 million people.
And you had to get consents from all of them?
No. So what we asked for is the leaders and the key stakeholders within those communities, would their community be willing to be part of what is basically a public health approach?
I see.
Now, you can choose, if you're somebody who lives in those communities, whether you want to accept it or not.
Right.
But within the communities...
You wanted to get a consensus.
Yeah.
That people wanted to work with us.
Mm-hmm.
And then within those 21 communities, we had a sort of randomization ceremony where people were allocated, communities were allocated, into one of the 3 different approaches we looked at. And we called those arms A, B, and C. And the only reason your community was within one of those 3 arms was a random allocation. So that's like the roll of a dice. And we did these in a very public ceremony in a kind of great big football stadium in Zambia. So everybody who wanted to come along could see how we'd given their communities that.
So that everyone could see it was completely fair and transparent.
Yeah.
And the 3 different sort of allocations were in our, what we call our Arm A communities. So that was 7 of these 21 communities were allocated to this intervention. We trained local people who lived themselves in those communities a bit about HIV. We taught them how to talk about HIV, how to educate people about HIV, to offer them finger prick HIV testing in their houses.
So this was a door-to-door service that was provided to everyone living in these communities.
Wow.
Universal.
And whilst they were in the household, they offered the education and the testing to everybody who was in that household, no matter how old they were, whether they were living there all the time or they were just visiting. And they also talked about voluntary male circumcision and the prevention approaches which included in that. They talked about symptoms of TB. They talked to people if they had they were unwell. We looked at TB, tuberculosis. And this was sort of package of care that was offered to a household. And these CHIPS teams, we called them, community HIV providers, went in teams around every single household in that community on an annual basis.
Almost like a health census.
Yeah. But they offered them the testing.
But it's like a service, right?
Yeah.
So the main thing, all those things were important, but the one single most important thing was that everyone should know their HIV status. So this is really important. That means you need to test, but not just once, you need to test regularly. So our CHIPS invited people to test and offered a test annually for everyone in the community. And then if they were positive, our CHIPS then helped them to get into care at the local clinic and to get onto antiretroviral therapy immediately without delay.
So you trained the trainers how to engage with the folks, and it worked. You got through all the communities by this reaching out like an octopus and getting all the contacts made.
I mean, I think we did incredibly well we visited nearly every household. So it wasn't quite 100%, but it was very close. So almost every household was visited each year. We didn't obviously see 100% of the people living in those communities, but we got pretty close. And we were trying to reach, they're called the 90-90-90 targets. I don't know if we should explain what those are.
Yeah, you can, because it's always good to re-explain.
Yeah, so these were, do you want to explain the 90-90 targets?
So the 90-90 targets were set up in 2014 by UNAIDS, and their idea was to test everybody in a whole community so that at least 90% of the population knew their HIV status. Now, of those entire population who know their status, they then said that 90% of those people living with HIV at least should be accessing antiretroviral therapy, and that 90% of all people living with HIV who were accessing treatment should have what's called an undetectable viral load, which means that they do not pass virus on, U equals U, and it means they don't get sick. And those targets were set up to try and push programs to deliver. Those targets do not tell us that if we achieve these, you will get to 0 new infections at a community level, but those are targets that have been incredibly good at pushing the agenda of getting people onto treatment.
So the good news for us was that we actually reached those targets during the study. So it was a 3-year study, and by the end of that period, we'd reached those 90-90-90 targets. So that's really important, because what we believe is that if you can get close to those targets, that should really reduce the amount of transmission from HIV positive people to their partners. And so that should reduce the number of new infections. So they call this treatment as prevention. So it's getting as many people as you can who are HIV positive to know their status and then to be on treatment and have their virus suppressed so that they don't pass it on to their sexual partners, their loved ones.
And then there needs to be a follow-up to make sure that we retain that kind of a situation.
So do you want to say how the CHIPS kept going back?
So these teams not only went round to a household once and tested whoever was there, but if they said, oh, my partner's at work and they'll be back later, they would go, I'll tell you what, we'll come back another time. So they really put an enormous effort into mopping up as many people who were willing to be tested and willing to be around as we possibly could. And if we found people were living with HIV, they would help them get onto treatment. They would literally go with them to the clinic if they wanted them to. And then they'd go back a couple of months later and go, how are you getting on? Did you get your medicines? How are you feeling? So there was a lot of engagement within those communities, and it took time, but
well, it takes time to get the trust of the community.
That's where I was going to go next,
it's really
because
important.
How do they receive the people who, were trying to engage with them? Did you follow that with any kind of?
Yes, we did, and it was an extraordinarily positive experience. So, of course, we spend a lot of time going to the countries and working with the teams in country, and this would never have been done without the enormous support from the local communities, the stakeholders, the implementing partners who were working in the clinics with us, but also our research teams in both countries. And these CHIPS teams were extraordinary, and the communities absolutely loved them. And they would walk through the communities and people going, oh, hi, come to my house. So once
So
they
do you remember
established trust.
what they told us was actually the first year it was more difficult because then you had to, that was the first time that people were seeing
They were like,
these.
it was all new.
Who
and
are
like,
you? Why are you coming?
Well, there's always this suspicion.
Yeah,
I mean, their lives have been, I guess there's this undercurrent of suspicion of the establishment.
That's right.
And you have to break through that. And what you've done, I think, is got people who were in the community to do this engagement, which was, of course, the first right step you took. And then from there on, I think following it up with, getting those people to meet and have some sort of understanding of what they're all doing and how did they do things better than another one. We've got to be more engaged with each other, and I think that's the only way to do it. Because
so then what they told us, so the second year they went round, already they could see it was quite different. People were welcoming them back. Oh yeah, you came last year.
A known quantity.
We were ready for you to come, and they found there was really trust. And I think we should just mention, you said, how important the role of our country teams was. Part of that was community engagement. So we had a very strong effort to engage with the community. We had, very strong community advisory boards, for example, working in every community. Right. And that played a very important role, I think. Don't you agree?
Do you have elements of the population that are unique and different that you feel you have to have that piece of it in that community advisory board? I mean, I don't know anything about Africa. I don't know that much about. I'm sure there's sex workers, there's men, there's mothers, there's other, and some people perceive themselves as gay, some don't, some trans, some heterosexual.
So some of the communities we work in, being overtly living as a gay man would not be acceptable, particularly in Zambia. But one of the ways we
with that label.
Yes.
Yeah.
One of
culturally
the ways
acceptable, in that local.
One of the ways we tried to address this, which is perhaps different from some of the other programs, is to say we really wanted this to be universal.
It's
we
for
didn't
everybody.
we didn't want to pick people out and go, are you a sex worker? Okay, we're going to test you. We went to every single household with the idea being that there was no special groups. HIV was a normal,
This is for
unfortunately,
everybody.
in those communities.
Everyone needs to get tested.
Well, I guess the question that I had was that more of when you had a community advisory board or community input, that you would have the pieces of the population that were to be represented. And I didn't know, I guess it's just natural that would happen. People would show up that...
We had a targeted program towards youth that was embedded within our work as well, and we had an adolescent community advisory board because, as I'm sure you know, the young people are very vulnerable to HIV, and so we had a specific group.
And also, they don't speak up if their elders are there. It's not quite like the States. They're very, in Africa...
They're respectful of their elders.
The elderly are respected, so you wouldn't
much
speak
as
up
it
as
is
a
in
young
China
person.
or Japan.
But we didn't, our community boards and I say our teams in country were better to speak to the specific question, but we didn't particularly go out and recruit key populations. We just invited people who wanted to be part of it. We were careful about having a gender mix, but we didn't particularly...
I think that's a good approach because it's hard to... I mean, that causes people to perceive themselves as being divided or segmented.
Well, there's
I think
a lot
we talk about we don't care who you are.
Yeah.
Everybody's at risk.
Yeah.
The face of AIDS is very diverse.
That was the way we approached it. So, there's a lot of stigma around HIV, but there's also stigma around sex work, about, sexual orientation in these communities. So by adopting, as Sarah said, this universal approach, we hoped that would reduce stigma because we weren't
I think
identifying...
it may change it.
We hope so, and in fact we're measuring that. Yeah. It's actually like an additional study that we're doing. We don't know the results yet, do we?
No, it's nothing that's going to happen quick.
No,
but
it takes time.
Different things like this may make the difference collectively over time.
Yeah, we hope so.
I think you really need to think about what you're doing because I think you're on the threshold of making some big differences. And the more people like yourself that interdict in a way that's very friendly and open and accepting, and with people that are that look like themselves, it's really essential. It's. I think we've started. I can remember when we did the first approaches to the homeless in places that I knew familiarly, and down in Florida. They had people we adopted people who were from the homeless population to go back out to the homeless population to talk to them. Because we felt that was a big part of the challenges that we faced. So I really appreciate the work you're doing. I can't tell you how much. It's just, and it seems like this is, and so what we're talking really about is education. And I think that I'm going to call this conference personally the education conference, because we're seeing so many pieces of it that people would say, oh, well, we already did that, or what? No, you have to continue to educate on over and over and over again, because you know that each year they come out with the mosquito. You get bit with a mosquito that's somebody else got bit. It might have been a person positive, and then you're going to be infected. Well, we know that's not true. There's a lot of things that aren't true.
Yeah, sure.
HIV is really a hard disease to catch, but given the right circumstances, it's not as easy. So we need to let people know the real reasons and learn how to engage themselves with the proper health department to take care of to know what they need to know and to get tested when they need to get tested.
So we're really grateful that you've spent all this time working with us on talking about the actual what we did. We haven't talked about the result.
There you go. Well,
So
we have to get to that.
this is important, isn't it? So
Yes.
the really important thing is we did find evidence that if you did this universal testicle
Yes.
treatment, it did indeed reduce HIV incidence, so the number of new infections. So it means that this is a valuable tool.
So, in other words, most of the times you can say, well, your best hope is that you're not going to get any more increases.
Yeah.
Because the chart goes up and up and up.
Yeah.
So yours decreased,
Yes.
which is profound.
Yes.
So
Profoundly
we
important.
compared the intervention, as we've explained to you, with 7 communities that just received whatever was we call it standard of care. So that's by no means they had no treatment. If you lived in those communities and you wanted to test for HIV, you could of course go to your local clinic. They would give you treatment. We made sure that all happened. It wasn't like we had an experiment where people didn't have medicines. But within our trial, we measured the number of new infections over the period of time of our study between the communities that received our intervention that we've just explained and those that were receiving whatever the government clinics were
Because
providing
you had the 3 groups, A, B, and C.
That's right.
So A was the one that received your...
So A received all the community health workers.
Right.
If you went to a clinic to get your treatment because you were living with HIV, in the A communities, even way before the guidelines shifted, you were offered treatment, didn't matter what your CD4 count is. In Arm B communities, we did exactly the same thing as Arm A, so they also received all the household testing and combination prevention approaches, but when they went to the clinic, they were offered treatment just according to guidelines. Now, I'm sure you're familiar with this, but the guidelines to start treatment used to be based on a CD4 count threshold that has subsequently gone to everybody. So during the time of our trial, Arms
still...
A and Arm B became the same.
Oh, right.
That makes sense?
Right.
About halfway through the trial,
yeah,
actually,
it went to
A and
everyone,
B became
yeah.
the same.
Gotcha. And then C was not...
See, the guidelines, if you went to a
Guidelines,
clinic in
yeah.
Arm C and you had a test and you wanted to go into treatment, they shifted their guidelines according to the country's...
But no door-to-door services.
I see. So what are your next steps? What are you going to do next? This is amazing work, and I only hope that you can either move this into other populations that are equally in need, or improve on what you've learned.
Let me make a start on that maybe, and you can suggest other things. So we've actually got a lot more analysis to do yet. We've only just started. We've looked at the main result, which is what we just mentioned, but there's a lot more
Lots
to
of
look at.
data to unpack.
Indeed,
Yeah.
including, for example, you mentioned stigma, so that's another thing we will be analysing quite soon. We're also looking at the effect we've had, if any, on tuberculosis, because these communities
Right.
also have
Right,
quite
right.
high rates of tuberculosis. And because our door-to-door services included screening people for symptoms of TB and referring them for treatment if they needed it. We hope that it's also helped to bring down TB rates, so not just HIV but tuberculosis. So we'll be looking at that in great detail.
Do you have any idea of how long it'll take to do this analysis?
Well, some of them quite soon. I mean, we've already started, obviously. By the time of the next big conference is in Mexico City in July, and we're hoping to report on the health economics study that we're doing. Was this cost effective? On mathematical modelling that we've been doing to try and understand the results, and also in July the stigma results will be reported. But the TB work, that's going to take a lot longer because we're actually going around the communities measuring that, and that's going to take another year or so. So that's a longer term.
Amazing work.
So the other piece of work that we haven't really mentioned perhaps in enough detail that we are talking about in Mexico as well is how we engage these communities. So we have an amazing team of social scientists and implementers who've worked very closely with the communities to go, how did it work? How could we do it better? And of course people need to know how much it costs. And every infection we prevent, of course, is cost saving, as well as people not getting sick because they go on to treatment. So two really important outcomes that our economists will look at. And then the mathematical modelers use the findings we have got from our trial to say, if you did this long term, so if the governments could actually
over a
implement
longer
this
period of time,
by 2030, what would be the impact? And again, they need all the numbers to work on that, but they should have those results, I think, by July.
Well, what they've already told us is it should build up over time. So if you can sustain
it's like a snowball rolling down a
exactly.
hill. Yeah. That's where I was going, because it's the thing that frustrates us so profoundly is that we really don't do what you did enough. And it's very frustrating for people that are pouring tons of money in, like Bill and Melinda Gates Foundation and Elton John Foundation and Bill Clinton, the Clinton Foundation. They're pouring tons of money in, and they want to see better results. So I think you're the example of what it is we need to be doing more of in many different ways.
Just on that one, we should say that the Bill Gates Foundation did support.
No, I understand.
They contribute significant amounts of money.
I would not doubt that. I would not doubt that. Just from your
hypothesis,
from your hypothesis, I would have encouraged him to do that. But it is important, and I think it's so good to get good results. They must be saying, where can we go with better? What can we do next?
What you've said is exactly right. That our findings suggest that this strategy should be a key part of what needs to be done to get towards the end of AIDS, as we talk about.
No more Band-Aids. Let's get to the end of this.
Exactly.
And it's almost like malpractice. What we've been doing for so many years. We know how to get where we need to go. You've demonstrated that, and so now if we don't implement it, it's malpractice.
We just need to do it.
Yeah, we need to do it. Just do it at this point. Yeah. So I thank you so much for what you're doing,
having us.
And certainly for being here on our program to do it for the audience, who I'm sure will appreciate knowing more about this kind of work.
Thank you so much.
It's very helpful.
Thank you for your time.
Thank you. Yeah.
Thank you.